In the previous video, we have discussed extensively on the anatomy and embryology of the thyroid gland. In this particular video, we will be concentrating on the physiology of the thyroid gland. So the core concepts that will be discussed under this heading will be on the synthesis, storage and release of the thyroid hormones. At the same time, we will be discussing on the transport of the thyroid hormones, and we are going to discuss about the various effects of iodine on the gland like Wool-Chaikoff and Jod-Bestow effect, and we also will be discussing on the basis of mechanism of action of this anti-thyroid drugs as well. And later on in the video, we'll be also discussing on the various types of deiodinases that are present in the body and how they are helpful in the peripheral conversion of T4 to T3, and at the same time, what is reverse T3 and what are the diseases that are resulting as a problem due to this inhibition of this deiodinases. And we'll also be discussing finally on the physiological changes in the pregnancy and about the thyroid hormone receptors as well. So this is the nutshell about the topics what we are going to discuss in this particular video. Before wasting much time, let us move on to the synthesis, storage and release of the thyroid hormone. So it is going to happen in stepwise process. There are going to be 5 different steps that you are going to discuss under this heading. So the first one is the first step, that is thyroglobulin synthesis, which means thyroid hormone synthesis usually kicks off or starts with the thyroglobulin synthesis only. This is step number 1. You can see there are 2 surfaces in the follicular epithelial cell. One is the basolateral side, which is going to face the blood. Obviously, this is true in many aspects. They are going to face the blood. That's the basolateral side. And the side that faces the colloid, that is otherwise referred to as follicular lumen. So that side we are going to call it as a apical side. Clear? Remember, the ingredients that are needed to synthesize this thyroglobulin is going to be one of the important amino acid. You know what amino acid that they need? It is tyrosine. This is the most important ingredient for synthesis of thyroglobulin, which means later on to synthesize this thyroid hormones also, this tyrosine is the most important ingredient that we need. So they take up this tyrosine from the basolateral side from the blood, and they're going to process it in the endoplasmic reticulum, and they're going to synthesize this thyroglobulin molecule. So once they have synthesized this thyroglobulin, they are going to release the thyroglobulin by exocytosis into the follicular lumen, and they concentrate this thyroglobulin in the follicular lumen, in the colloid. So step number 2. Step number 2 involves iodide handling. So now we have synthesized the thyroglobulin. Now we have to take up and process the iodide. So iodide handling involves 2 steps. One, they have to take up the iodide first from the basolateral side. From the basolateral side, they have to take up the iodide, and this taking up of iodide from the blood from the basolateral side is done by a very important transporter called sodium iodide symporter. This sodium iodide symporter works something similar to that of a secondary active transport. You can see here the sodium and iodide both are taken at the same time, but the cell is not going to like the sodium, so it's going to spew out the sodium in the form of this sodium potassium ATPase, which means they don't directly use the energy, the sodium iodide symporter, but by virtue of putting sodium inside, which has to be pushed out, it uses energy indirectly in the form of ATP. That's why it can be considered as a form of a secondary active transport. Clear? Or you can understand in a different way also, the gradient that is created by this sodium potassium ATPase, that more sodium outside and less sodium inside, is going to be useful for the sodium iodide symporter, because then only as the because the gradient created by this pump, the sodium will move into the pump in the form of sodium iodide symporter. You can understand in that reverse way also, but anyway, it is going to work like a secondary active transport. So now by virtue of this pump, you have concentrated iodide inside the cell, so which is going to enter the common iodide pool. But the idea of synthesizing thyroid hormone is going to be like you have to push this iodide out of the cell to concentrate this iodide in the colloid, right? Then only it can come with the thyroglobulin and they can produce the thyroid hormones. So this concentration of iodine in the colloid, they have to push the iodide out of the cell through the apical membrane into the colloid, and that process is done by a very, very important protein called pendrin, which means I can write here the iodide transport through the apical side of the thyroid epithelial cell is done by a very important transport protein called pendrin. Obviously, it is synthesized by the pendrin gene, which is present at chromosome number 7. Defects of this pendrin gene and resultant pendrin protein can result in a syndrome called as Pendred syndrome, which is autosomal recessive in inheritance. You know what are the effects of Pendred syndrome? Obviously, there is going to be hypothyroidism, but usually it will result in mild hypothyroidism, surprisingly. But it will result in sensorineural hearing loss, and this is the most important defining feature of a Pendred syndrome, because 10 to 15% cases of congenital deafness are due to Pendred syndrome. So you have to understand that. That's why this is a really important syndrome. Fine. Because why you get sensorineural hearing loss in Pendred syndrome? Because pendrin protein is important in 3 organs: thyroid, cochlea, and in the kidneys. But unfortunately, they don't result in kidney disease, but still they do result in thyroid disease, and even more severely, the cochlea will be affected, resulting in sensorineural hearing loss. Okay, now you have known some points about the iodide handling. Number 3, you have to synthesize the thyroid hormones. So how they are going to synthesize the thyroid hormones? To synthesize the thyroid hormones, you need a very, very important and a unique enzyme that is seen in the thyroid gland, that is TPO, that is thyroid peroxidase. Clear? So what are the functions of thyroid peroxidase? Now you know that thyroglobulin is now concentrated in the colloid, and your iodine is also concentrated in the colloid. So now you have this thyroglobulin and iodide. Both are concentrated in the colloid. But remember, this iodide has to be first converted to iodine. Then only they can combine with the thyroglobulin. So this iodine formation from iodide has to be done by a process called oxidation. So this oxidation process is actually mediated by this thyroid peroxidase. So step number 1, you know very well, that is oxidation step. Oxidation of iodide to iodine. Number 1, that is done by thyroid peroxidase only. For this oxidation to happen, you need this hydrogen peroxide, and this hydrogen peroxide to form, you need another enzyme that is called as NADPH oxidase. NADPH oxidase. Obviously, you have studied this enzyme in the hematology section itself, where in the basics of cellular mechanisms of innate immunity, I have discussed about the respiratory burst, and I have discussed definitely about the NADPH oxidase enzyme as well. So which is going to use this, produce this H2O2, and this hydrogen peroxide produced by this NADPH oxidase is going to be utilized by this thyroid peroxidase to produce this oxidation process in converting iodide to iodine. So once the iodine has been formed, it is going to mix with the thyroglobulin molecule. So if you see, this is the thyroglobulin molecule, and they have a lot of tyrosine residues in the thyroglobulin, which is going to mingle with this iodine. This tyrosine molecules mingling with the iodine is the thing that we want. Actually, they are going to result in formation of compounds like MIT and DAT. This is otherwise referred to as a monoiodotyrosine, and second one is called a diiodotyrosine. Clear? So there is one more step that is happening in the thyroid gland after this oxidation process, and that is also mediated by the thyroid peroxidase enzyme, that is called organification process, organification of iodine. So what do you mean by this organification of iodine? Remember, this iodine is an inorganic compound, but thyroglobulin is an organic protein compound. So this thyroglobulin and iodine, when they mix with each other, the iodine gets organified. By adding an inorganic iodine to organic thyroglobulin, the iodine becomes organified. So this is what we called as organification of iodine. So which means at the end of organification process, you are going to result in MIT and DAT formation. And this is also very crucial step, and this is also performed by your famous thyroid peroxidase enzyme only. Then next step, once this MIT and DAT has formed, this MIT and DAT now will mix with each other, and MIT plus DAT is going to result in formation of T3, that is triiodothyronine, and 2 DAT molecules can mix with each other to produce tetraiodothyronine, otherwise called as T4, or famous thyroxine molecule. And this process where they mix and produce these thyroid hormones is what we refer to as coupling process. So this is the third step that you have to know, and this is also mediated by the famous thyroid peroxidase enzyme only, that is coupling process. So third thing I can write, coupling process. in the formation of thyroid hormones is also mediated by this thyroid peroxidase enzyme only. At the end of this coupling process and end of all these processes, the thyroid hormones have synthesized, but you can see MIT, DIT, T3, T4, all these are actually attached to the thyroglobulin still. They are not yet released as active hormones. So they are yet in, like bonding with the thyroglobulin molecule only, and they are still concentrated in the colloid. And that's what the fourth step is, that is storage. Storage of the thyroid hormones. Storage happens in the colloid, and during storage, the thyroid hormones will still be linked with the thyroglobulin molecule only. Along with that, many MIT and DIT molecules will still be linked with the thyroglobulin molecules. So final step is the release of the hormones. Release, in fact, again takes a lot of steps, 3 steps to be precise. First step in the release is going to be endocytosis. So this colloid has to be endocytosed, which means when I tell the colloid has to be endocytosed, you have to tell that it's not the colloid that is endocytosed, it's the thyroglobulin molecules that are endocytosed. Once they are endocytosed, they will be fused with the lysosomes and they form an endolysosome. And in the lysosome, inside the endolysosome, there is another event that is going to happen that is called proteolysis. So next step is the proteolysis. There will be proteolytic cleaving of the bonds, resulting in release of different molecules from the thyroglobulin. Like for example, the T3 and T4 will be freed from the thyroglobulin during this process, and next your MIT and DIT will be freed, whatever MIT and DIT is attached to thyroglobulin, and thyroglobulin itself will be broken down into small amino acid and other protein fragment pieces. So the T3 and T4 that is freed through this step is now released into the circulation through a transporter called MCT8. So this is the final step, that is the release of thyroid hormones, T3 and T4, done by a transporter called MCT8. At the same time, the remaining amino acids, whatever that is released by breaking down the thyroglobulin molecule, is going to be reused again. And this MIT and DIT that is again freed from the thyroglobulin molecule through this proteolysis step is going to be recycled through a very important enzyme called deiodinase. Remember, this deiodinase is what we refer to as a iodotyrosin deiodinase, because they break down the monoiodotyrosin and diiodotyrosin. That's why they are called as iodotyrosin deiodinases. Once the iodotyrosin deiodinases act, they are going to release this iodine and iodide from the MIT and DIT molecules, and this iodine that is released is going to enter again the common iodide pool, and this process what is referred to as something called a iodide salvage. And once these molecules enter the common iodide pool, they will be taken back once when you need this iodide for synthesis of new thyroid hormones. Clear? So I would like to tell this iodotyrosin deiodinase related points. Why? Because many students get confused when they see this word deiodinases. Because there are 2 types of deiodinases. One is called iodotyrosin deiodinases, and second is the iodothyronin deiodinases. What are the basic difference? Remember, this iodotyrosin deiodinase is predominantly present in the thyroid gland itself, in the thyroid epithelial cells, where their targets are going to be MIT and DIT. Clear? At the same time, this does not use selenium and a 21st amino acid called selenocysteine. Selenocysteine is not important for the action of this iodotyrosin deiodinases. But this iodothyronin deiodinases are present in the periphery, not in the thyroid gland. Periphery in the sense in the target glands or in the target areas, target cells where the thyroid hormone is going to act upon. So there are multiple types of iodothyronin deiodinases like D1, D2, D3, which we are going to discuss in detail in the next slide. At the same time, the target for this iodothyronin deiodinases are T4, T3, and a molecule called reverse T3. Like these are going to be the targets for this iodothyronin deiodinases. Clear? So reverse T3 is inactive form of thyroid hormone. So we'll discuss in detail about this in the later subsequent sections. At the same time, for the function of this iodothyronine dehydrogenases, you need selenium in the form of this 21st amino acid, which is often referred to as selenocysteine. Clear? So these are the basic differences between these dehydrogenases. So here, what I mean that is acting in the thyroid gland is the iodotyrosine dehydrogenases and not iodothyronine dehydrogenases. Clear? But you all know that T3 and T4, even though T4 is released in excess from the thyroid gland compared to that of the T3, there are a lot of reasons for that. But you can clearly see that T4 is released in larger amounts. 80% of the thyroid gland's output is in the form of T4, and only 20% of the thyroid gland's output is in the form of T3. But in the periphery, this T4 is going to get converted to T3 inside the cell by this dehydrogenase only. If they ask you what dehydrogenases in the periphery convert this T4 to T3, you have to surely tell that it is iodothyronine dehydrogenases. Clear? That's why I told you this point. Inside the thyroid, iodotyrosine dehydrogenases. In the periphery, for peripheral conversion of T4 to T3, you need this iodothyronine dehydrogenases. Clear? So that gives our conclusion that differences between T4 and T3. What are the difference between T4 and T3? Remember, T4 anyway in the periphery, they will be converted to T3. Inside the cell, T3 is the active hormone inside the target cell. It's not the T4. So T4 I can even consider as a prohormone, whereas T3 is the active hormone. I already told you 80% of thyroid output is in the form of T4 only. Only 20% of the thyroid output is in the form of T3. Right? And next, plasma T3. Plasma T3 is actually very less. Plus plasma T4 is very high. There are two reasons why plasma T4 is in excess compared to that of the plasma T3. One, because output from the thyroid gland is principally T4. Second reason, the half-life of T4 is very high, like approximately 1 week, 7 days. That is the half-life of plasma T4. But the half-life of plasma T3 is very low. It's only 1 day, that is only 24 hours. Which means these two are the contributing factors. Output from the thyroid gland is very less. At the same time, the half-life of the plasma T3 is very less, and these two are the major contributing factors of, which tells you why plasma T3 is lesser compared to that of the plasma T4. At the same time, remember whatever T4 that you see in the plasma. Let us also understand the various mechanism of this antithyroid drugs, how the antithyroid drugs are going to work. So let us block in sequential process in the synthesis and release steps. The first step that we can block is the uptake step, where you can block the sodium iodide symporter. And the compounds that block this sodium iodide symporter are the perchlorates. Remember, perchlorates are very high in the soil of Mars. It's been proven that perchlorates are very dangerous to the human body and they can kill us fast. And thiocyanates. Thiocyanates also can block the sodium iodide symporter, and various nitrate-related compounds. They can also block the sodium iodide symporter. So these are the uptake inhibitors, and even though these are considered as antithyroid drugs, these are no longer used because of their excessive toxicity and not recommended for the current use. But there are a lot of other drugs that are antithyroid drugs. One is the TPO, that is thyroid peroxidase inhibitors. So what are the thyroid peroxidase inhibitors? These drugs are famously referred to as thionamides. And there are 3 drugs under this group. One is methimazole, second is carbimazole, and third one is the propylthiouracil. Remember, even though we are going to dissect this thionamides extensively in the Graves' disease section, but right now understand this methimazole remains the most potent, strongest antithyroid drug ever discovered. And this propylthiouracil is the weakest thionamide ever discovered. Clear? This is not strong at all because propylthiouracil dose is usually in grams. You have to give very high dose. But one unique advantage of propylthiouracil is the fact that high doses of PTU can actually inhibit the peripheral dehydrogenases, which means, what I mean by peripheral dehydrogenases means I can inhibit the iodothyronine dehydrogenases. you know, this deadenase are the ones that convert the T4 to T3 in the periphery, which means propyltyrosine can block the peripheral conversion of T4 to T3. And among the thienamides, this is the only drug that has this ability. Methimazole and carbimazole cannot inhibit the peripheral conversion of T4 to T3. You have to be very clear about that. Clear. And the next antithyroid drug is iodide itself. Iodine and iodide itself can act as a antithyroid drug. How iodide works and what are the areas where iodide blocks? Iodide blocks at two steps. One, they are going to block the TPO, especially this organification step. So this step is the target for iodide. So number one, it is a synthesis inhibitor, which means they are going to block the organification step. This blockade of the organification step by blocking the thyroid peroxidase activity, specifically at the targeting the organification step, is what we refer to as Wolff-Chaikoff effect. We'll discuss that in some time. That's what we refer to as a Wolff-Chaikoff effect. But remember, at the same time, they can also inhibit the release of the thyroid hormones. Actually, this release of thyroid hormone inhibition is more clinically relevant compared to the synthesis inhibitor inhibiting action. But let us see how in what step in the release process they inhibit. They actually inhibit the proteolysis step. That's what they do. So if they ask you where iodide acts, they are going to act as a proteolysis inhibitor. So by these principles, iodide is a powerful antithyroid drug as well. Remember, iodide blocks the synthesis as well as the release, but whereas your thienamides are only synthesis inhibitors. They are not release inhibitors. They only block the synthesis. Clear? Finally, you have radioactive iodine, which is also an antithyroid drug only. Radioactive iodine works by a different principle. They destroy the gland, especially a molecule called I-131. Half-life of this molecule is 8 days approximately, and they're going to emit beta and gamma radiation both, and they are commonly used for ablative purposes. Why I told you this many points about this I-131? Because you have another compound called I-123, which is half-life is only 13 hours, and it's going to emit only gamma, and it is used for diagnostic purpose and not ablative purposes. Remember, I-131, because of the higher half-life and more radiation delivered, they are used for ablative purposes. When you give this I-131, it will be taken up by the same sodium iodide importer only. In this, I-131 is going to enter the cell and it will be concentrated in the iodide pool. And after that, it will get concentrated in the colloid as well. So I-131 that is going to emit radiation inside the follicular epithelial cell as well as from the colloid is going to destroy this particular follicular epithelial cells. That's why for ablation of the thyroid gland, you can use I-131 because you are going to induce radiation related damage. Okay. Now let us see the effects of iodine on the gland. So now we know about the antithyroid drugs. Now we'll move on to the effects of iodine on the gland. Remember, the most important effect of iodine is going to be the Wolff-Chaikoff effect. Wolff-Chaikoff effect. What do you mean by Wolff-Chaikoff effect? Reasonably large doses of iodine is going to block the gland. How they block the gland? They inhibit the thyroid peroxidase enzyme, especially the organification step. This inhibition of this organification step is what we refer to as Wolff-Chaikoff effect. Remember, they are also release inhibitors, but specifically this inhibition of organification is what we define as Wolff-Chaikoff effect of iodine. So how this work? They are going to take up the iodine. So if you give excess iodine, let us assume you are giving this excess iodine. So now iodide is in excess and you are giving this large dose of iodine, which means iodide is also going to get concentrated in excess inside the thyroid follicular cell, right? So this excess iodide will be in the iodide pool and not be immediately taken into the colloid to get concentrated and produce thyroid hormones. Instead, these iodides that are in excess will start combining with other different proteins apart from thyroglobulin inside the cell itself, and they will result in the formation of iodopeptides. These are different from thyroglobulin and tyrosine monad MAT or DAT molecules. They form combination with different proteins inside the cell, and they're going to form a group of molecules called iodo-peptides. And these iodo-peptides are supposed to inhibit this TPO step, especially in the organification step. So how they are going to inhibit the TPO? Because these iodo-peptides can inhibit the TPO mRNA, thyroid peroxidase mRNA, which means once they inhibit the thyroid peroxidase mRNA, they will be down-regulating the production of thyroid peroxidase protein, which means reduced thyroid peroxidase means reduced organification process. So this is what we refer to as a Wool-Chekhov effect. This is the basic mechanism. Even though it's only speculative, it is not confirmed mechanism behind how Wool-Chekhov effect happens, but still this is what is the proposed mechanism. So now you know how iodine can block the gland by Wool-Chekhov effect. But remember, this block will not be for a long time. After 2 to 8 weeks time, the gland will escape from this Wool-Chekhov effect, referred to as Wool-Chekhov escape. It will not be forever. Within 2 to 8 weeks of time, the gland will escape. How the gland is going to escape? You know that the reason behind this Wool-Chekhov effect is concentration of this iodine molecules inside the cell, and that is the reason for the formation of iodo-peptides, which ultimately results in declining TPO activity. But you can down-regulate this sodium iodide symporter activity, which means they are no longer going to concentrate this iodide inside the cell, which means the iodide pool drops and the formation of iodo-peptides will no longer happen, and the inhibition of TPO mRNA no longer happens, and the TPO will start getting expressed once again. And once again, all this process will start and they are going to release the thyroid hormones. And this is what we refer to as a Wool-Chekhov escape. But one important thing that you have to understand is the fact that there will be another term coined in your physiology textbooks called as autoregulation. What do you mean by autoregulation? Whenever you give iodine in large doses, initially there will be a block in the gland followed by escape from the block. And this entire process of block followed by escape is what we refer to as autoregulation. For that matters, there can be defective autoregulation. Suppose if this autoregulation is defective, it's not working properly. So where it can happen in any patient with pre-existing thyroid disease like thyroiditis, or it can be due to Graves' disease or any condition which has pre-existing thyroid disease may have, I'm not telling always have, may have a defective autoregulation. So which means there are two effects that is possible because of this defective autoregulation. One, they will not have any block at all, which means there will not be any Wool-Chekhov effect at all. Instead, whatever iodine you give, this iodine will only promote synthesis of thyroid hormones. They will not cause any block at all. This is one of the forms of defective autoregulation, and which means this is going to result in hyperthyroidism, not block and hypothyroidism. So this is what we refer to as something called a Jod-Bezdow effect. So Jod-Bezdow effect will operate whenever you have a defective autoregulation when the patient is having a pre-existing thyroid disease. And this effect is really important because that is the reason why we treat thyroid storm in a little different way. I'll explain you in some time. And next, if there is prolonged block, which means I told you even if there is an initial block, there should be an escape after 2 to 8 weeks time. But if the escape doesn't happen and if there is a prolonged block, the patient will have a prolonged hypothyroidism. And this is also a form of defective autoregulation. This is also possible in a patient who is having a pre-existing thyroid disease. Either there is no block or there can be even a prolonged block. Or there can be a faster escape also, which is again going to result in hyperthyroidism and Jod-Bezdow phenomenon. Clear? So these are the problems that you get because of the defective autoregulation. Remember, iodine-induced hypothyroidism is called Wool-Chekhov. Iodine-induced hyperthyroidism is what we refer to as Jod-Bezdow. Wool-Chekhov is the normal mechanism, but Jod-Bezdow usually happens in patients with pre-existing thyroid disease due to defective autoregulation, where there will be no Wool-Chekhov effect at all. Okay. So these are some of the effects of iodine that you have to know on the thyroid gland. With this, we can move on to the transport of the thyroid hormones, how the thyroid hormones are getting transported in the blood. Transport happens through 3 different proteins. One is the thyroid binding globulin. Second one is the transthyretin, TTR, which is otherwise referred to as prealbumin. Currently, we don't use this term. We use the term only called transthyretin. And third one is called as albumin itself. So why you need transport proteins? I told you this thyroid hormone is a type 1 or a group 1 hormone which is lipophilic. In fact, the only amine and peptide based hormone that is lipophilic is thyroid hormone only. Remaining all the amine and peptide based hormones are actually hydrophilic and they come under this group 2 hormones. Along with the steroids, the only amine and peptide based hormone that is lipophilic is this group 1 hormones. One of the characteristic feature of this group 1 hormones, which I have discussed in the video number 1 itself, is having transport proteins in the blood. That's why thyroid hormone is carried by these transport proteins. So let us see what are going to be the differences. Remember, by default, this TBG is going to have the highest affinity. For the same reason, the circulating T4 is going to be predominantly bound with the TBG only. Whatever T4 that is seen in the circulation, at physiological levels at least, you are going to have binding with the thyroid binding globulin only, not with other compounds. And TTR, on the other hand, has moderate affinity, whereas albumin is going to have reduced affinity comparatively. Clear? And levels of TBG, if you ask, it's going to be very less, but albumin's levels are relatively high. So high levels coupled with multiple binding sites. If they ask you amount of binding sites, you have multiple binding sites. So high levels compared to that of TBG and TTR coupled with multiple binding sites will tell you that albumin is the one that is going to have the highest capacity to carry the thyroid hormones. But they have moderate capacity. I mean, because of the levels are little high but not that very high. At the same time, they have two binding sites. That's why they have moderate capacity. But TBG levels are very low. At the same time, they have only one binding site. That gives us a conclusion that TBG is having the least capacity for carrying the thyroid hormones. But remember, majority of the circulating T4 are bound to the TBG only, courtesy to the highest affinity that the TBG has for thyroid hormones. Okay. Now, what is the half-life of these molecules? Half-life of albumin, we know very well. It's going to be approximately 21 days. This is a well-known fact. Half-life of TTR is approximately 2 days and half-life of TBG is approximately 5 days. And the synthesis happens in the liver for albumin and TBG, and even for the transthyretin, the synthesis will happen in the liver. But please do remember that synthesis of TTR also happens in the choroid plexus and the eyes. Choroid plexus and the eyes. But I will tell about this choroid plexus as an important note because this TTR forms a very important carrier protein of T4 in the CSF. In the CSF, the major carrier protein for thyroxine is TTR only, transthyretin only. That's why this choroid plexus point is really important. They are synthesized in the eyes as well, TTR. And a lot of conditions can alter the TTR and albumin levels. But the two most important conditions that alter the TTR and albumin is the inflammation and nutrition. For example, I can tell malnutrition. Remember, TTR and albumin are more of nutritional markers. That's why. In that, inflammation and malnutrition both are going to reduce the levels of TTR and albumin. Why? Because if you take the hematology section again where you have studied in the acute phase reactant, in the innate immunity section in the humoral part, I have given a list of acute phase reactants. In that I would have told this albumin and TTR as negative acute phase reactants, which means their levels are going to decline in inflammatory states, especially in chronic inflammation. But there are multiple conditions that can alter the levels of this thyroid binding globulin. So why that is important? Because whenever the thyroid binding globulin levels are high, the total T3 and T4 levels will increase. But this has little clinical significance because the free T4 and T3 is the one that really matters. Because that is the one that is going to have physiological effects, not the total T3 and T4. Remember, but total T3 and T4 will be still in equilibrium with the free T3 and T4. So in that way, they can affect your system. But total T3 and T4, in reality, they don't have much clinical relevance. Whenever you have a reduced TBG, and again your total T3 and T4 will be reduced. And this is the reason why we currently prefer doing free T3 and free T4, not the total T3 and T4, because a lot of conditions can affect the status of total T3 and T4 because of the alteration in the levels of the thyroid binding globulin. So now let us see what are the conditions that will increase the TBG and what are the conditions that will reduce the TBG, thyroid binding globulin. In that I can divide into two. First, the drugs that increase TBG or decrease TBG, and the pathophysiological conditions that is going to increase the TBG and decrease the TBG. What are the drugs that are going to increase the TBG? First is estrogens. Any estrogen can increase the level of TBG. Next, estrogen receptor modulation like tamoxifen. And this is an exam material. Many times they have been asked in institute exams like JIPMER, AIIMS and PGA. Tamoxifen can increase the TBG levels. Apart from that, nicotinic acid can increase TBG. Drugs like 5-fluorouracil, clofibrate, and opioids like heroin and methadone can increase the TBG. What are the drugs that decrease the TBG? The counterpart of estrogen will be androgens. And a lot of anabolic steroids, including danazol. Danazol may be considered as an anabolic steroid, and even glucocorticoids can reduce the TBG. Clear? Other drugs that can reduce the TBG include L-asparaginase. 5-fluorouracil is an anti-cancer drug that increases TBG. Similarly, L-asparaginase is an anti-cancer drug that can reduce the TBG. And salicylates, interleukin-6, all this can actually reduce the TBG levels. And next, what are the pathophysiological states that can alter the TBG? Pathophysiological states that can increase the TBG include any form of hepatitis, like acute or chronic. Because you can remember, hepatitis is an inflammation of the liver cell where the cells might get destroyed and they will release the proteins, whatever they are stored. And that is the reason why AST and ALT is also getting elevated. That is also stored in the hepatocytes only. So probably that is the reason why TBG levels are also getting elevated. And you can get in pregnancy because pregnancy is a hyperestrogenic state. We know that. And patients who are having hypothyroidism, because TBG should expand to increase the carrying capacity of T4. Whatever T4 is available, they have to be carried through this TBG molecule only. So that's why TBG may be increasing with hypothyroidism. And you can increase with a condition called acute intermittent porphyria, and you can increase in the patients with hepatocellular cancer and primary biliary cirrhosis, and it can increase in patients who are having angioneurotic edema, and probably in patients who are having HIV as well. These are some of the conditions. What are the conditions that reduce the TBG? Liver failure, obviously. There is no cells to synthesize this TBG at all. It's a failure. Then in nephrotic syndrome, that is because of heavy proteinuria and leakage of this TBG in the urine. Then in critical illness, including sepsis. And I told you the glucocorticoids are going to reduce the TBG, which means its equivalent pathological state is Cushing syndrome, which will have reduced TBG. And malnutrition obviously reduce synthesis of TBG because the TBG may be reduced, and chronic alcoholism, which is equivalent to malnutrition only. And finally, you can have reduced TBG with acromegaly as well. So these are the some conditions which is going to reduce the TBG or increase the TBG, and the tamoxifen is the most important of all because it's an exam question. Probably if I wanted to frame the question paper, I'll be asking this anabolic steroids, danazol, glucocorticoids, then probably liver failure versus hepatitis, pregnancy, nephrotic syndrome, then patients are having Cushing syndrome. So these are the things I will test if I am the examiner. So please note these points also before going to the exams. Clear? These are the conditions that are going to alter the thyroid binding globulin levels. So now you know how the thyroid hormone is transported in the system, in the body. But before going into the effects of the thyroid hormone in the body, let us also discuss on what are the facts on iodine as such. So facts on iodine. The recommended daily intake or recommended dietary intake of iodine is approximately 150 microgram per day in a standard adult population, of which 80% is actually utilized by the thyroid gland only. Thyroid is the one that is going to gobble up this 80% of daily intake of iodine. But in pregnancy and lactation, RDA will increase to 200 micrograms per day, because lactating mothers are really important, because the neonate completely depends on mother for its nutrition. So the breast has to concentrate this iodide in the breast milk. That's why they have the sodium iodide symphotus in the breast in high amounts, because the iodine that is in the breast milk is needed for the neonate's thyroid to keep going. So you need that iodine. So the mother needs excess iodine. And in neonates, you need 40 micrograms. It's understandable, because that's the reason why pregnant mothers and lactating mothers need that excess 40 to 50 micrograms per day compared to the standard adult. The richest source of iodine by far is the seafood. Seafood is going to be the richest source of iodine, in all the food materials that have been found. That's also the reason why people living in hilly areas are prone for iodine deficiency and goiter and hypothyroidism, because they don't have access to the seafood. And second thing, vegetarians are also prone for this iodine deficiency. To avoid all these problems, only Government of India has taken many steps. In that, one of the very easy and special steps that they have taken is making this iodized salt mandatory. And remember, the content of iodine as per the regulation that should be present in the iodized salt is approximately 150 parts per million. So this should be the content of the iodine. And as of 2013 data, 91% of the people living in India are taking the iodized salts as of now, and the numbers are keeping on increasing because of the continuous efforts of Government of India, at the same time awareness of the people as well. Next, let us see the storage of iodine. How much iodine are present in the stores in the body? The stored iodine contributes to approximately 15 to 20 milligram, of which again 80% is seen in the thyroid. 80% is seen in the thyroid only. So this stores, how long it will last? If you remove the iodine completely from the diet, this stores will last for approximately 2 months. Clear? They last for approximately 2 months. So all these are very important points, and everything has been asked in the exam. Clear? So now let us study the physiological effects of thyroxine. So remember, effects can be divided into effects on the heart and the effects on the lungs and the effects on the skeletal muscle, effects on the skeletal muscle, and the effects on the metabolism, effects on the metabolism, and the effects on the growth as well. Effects on the growth as well. Clear? First, what are the effects on the heart? You know, thyroxine is the one that's going to be causing chronotropic as well as inotropic potential on the heart, which means they are going to increase the heart rate, they are going to increase the stroke volume, they are going to increase the contractility. Because they increase the heart rate and the stroke volume, they are going to increase the cardiac output as well. Next, what are the effects on the lungs? In the lungs, they are going to increase the oxygenation. How they increase the oxygenation? By first principle, they increase the pulmonary blood flow because the heart contracts excessively. At the same time, they increase the ventilatory drive. They increase the respiratory drive, and they increase the breathing rate also by stimulating the respiratory center in the brain. So because of that, they will try to increase the oxygenation. Why they increase the oxygenation? Because they are going to increase the basal metabolic rate, which means they are going to increase the oxygen consumption by the cells. When they need to increase the oxygen consumption, they have to increase the oxygenation. Then only it's possible. So both will be activated simultaneously. Remember, this excessive BMR and excessive oxygenation will happen in almost every single organ in the body, but there are certain exceptions. These organs are not susceptible to the effects of thyroxine by causing increased oxygenation. Increased oxygen consumption. What are these organs? Obviously, it's the brain and the pituitary, and obviously the gonads like testis and ovary and uterus, and the lymph nodes and the spleen. So these organs are actually not susceptible to the thyroxine effects of increasing oxygen consumption. How they increase the BMR and how they increase oxygen consumption? At a molecular level, you have to know that they are going to activate the sodium potassium ATPase. That's how they do that. And they consume more ATP, and because of that, they consume more oxygen at a molecular level. And this is another crucial point to understand, because there is an entity called thyrotoxic periodic paralysis, where patients will have hypokalemia and subsequent paralysis. The reason is because excessive thyroid hormones can activate the sodium potassium ATPase excessively, resulting in more potassium movement into the cell, causing transcellular movement of potassium from ECF to the ICF, causing hypokalemia and subsequent paralysis. That's why this point is again very important to understand. Clear? And apart from that, they can have a lot of other metabolic effects. For example, they can have metabolic effects on the fat, they can have metabolic effects on the proteins, and they can have metabolic effects on the carbs as well, carbohydrates. What are the metabolic effects on fat? They are going to increase the lipolysis. Yes, and that's one of the reasons why they cause weight loss in hyperthyroid states. At the same time, they can also stimulate the formation of LDL receptors in the liver, or expression of LDL receptors in the liver will increase. And this is a very important point again, because when you don't have thyroid hormones, so for example, thyroxine is stimulating the expression of LDL in the LDL receptors in the liver, which means they will capture a lot of LDL and they will internalize, which means the circulating LDL will reduce. When you don't have this sufficient thyroxine, hypothyroidism, the LDL receptor expression will decrease, which means there will be more and more circulating LDL in the blood, resulting in dyslipidemia. One of the important effects of hypothyroidism is higher circulating LDL, which might predispose to higher cardiovascular risk and MI in these patients as well. Then protein metabolism, it can be anabolic or it can be catabolic also. But remember, anabolic effects happens at physiological levels. At pathologically excess states, you will result in catabolism only, and that is also one reason why they are going to result in weight loss in hyperthyroid states. And carbohydrates. Carbohydrates, again complex. They can accelerate the gluconeogenesis. Clear? At the same time, they can increase the glucose reabsorption from the intestine and the kidney as well. So by this principle, they are going to result in hyperglycemia. And this is a very, very important point, because hyperthyroidism is one of the important causes of hyperglycemia, which means it's one of the important endocrine causes of hyperglycemia and diabetes. We'll be discussing diabetes. That time I will tell you hyperthyroidism is an important cause. At the same time, why I told you it's complex, because they will increase the glucose utilization by the cells also. They will increase the glucose oxidation by the cells as well. At the same time, they will increase the glucose utilization by the cells, and they will increase the glycogen synthesis also. They will increase the glucose levels. At the same time, they are going to increase the utilization of the glucose by oxidation and increase the glycogen synthesis also. All these are effects of thyroid hormones. So the increase in the BMR and increase in all this lipolysis and all can be understood by one important principle, that thyroid hormones are going to potentiate the catecholaminé action, which means you have this catecholamines which are going to act on the cell surface receptor. This catecholamines has to activate some of the proteins inside the cell, and this action has to be mediated by a lot of proteins called as signal transducing proteins. And the signal transduction is really important for the translation of these effects of catecholamines that are actually binding to the cell surface receptors, and that has to be translated into effects inside the cell by the signal transduction molecules. And thyroxine actually is going to stimulate the signal transduction molecules, or they are going to accelerate the signal transduction caused by this catecholamines, which means that is how thyroxine is said to potentiate the catecholamine action. Thyroxine is said to potentiate the catecholamine action. Clear? Thyroxine is said to potentiate the catecholamine action. That point is very important again. So that is the reason why in hyperthyroidism you will see conditions, the clinical effects will be similar to that of a hypersympathetic state or hypercatecholamine state, like tachycardia. Then probably you might result in sweating. So you might result in hypersympathetic state. So because they are going to potentiate this catecholamine action, that's one of the basic molecular level mechanisms that this thyroxine is going to have. And the effects on the skeletal muscle, they are going to increase the proliferation and production of a special type of muscle fibers called type 2 muscle fibers. This is really important. Clear? These type 2 muscle fibers are also referred to as fast twitch fibers, which are going to be helpful in faster and very powerful contractions. Clear? But it will not be contracting for a long time. They will fatigue fast, but still sudden, fast and powerful contractions, you need this fast twitch fibers, type 2 muscle fibers. And growth effects of thyroxine is very important for fetus and the children, especially the fetus. The nervous system growth actually is dependent on thyroxine. That is the reason why congenital hypothyroidism can result in cretinism, which can be having the children might be having low IQ and mental retardation. At the same time, this is also important for bone growth in children and infants. How they promote the bone growth? Because they can activate a variety of cells in the bone like osteoblasts, chondrocytes and even osteoclasts, and they can promote bone remodeling as well. But later on, the effects of thyroxine on the bone will diminish as the child grows into an adult. But in the initial phases, at least, this thyroxine is really, really important. At the same time, they can simulate the growth hormone synthesis and release also. Thyroxine can increase the growth hormone synthesis and release, and by virtue of that also, they can accelerate the growth of the bones in children. So these are some of the physiological effects of thyroxine that you have to know. In this, the most important and relevant effect is the increased heart rate. That is the reason why in hyperthyroidism, they can go for tachycardia and even cardiomyopathy. And even there is a risk of development of atrial fibrillation in case of hyperthyroidism. That's why it's important. And the effects on oxygen consumption is important. And this is because of the activation of sodium potassium ATPase, and because there is a clinical understanding behind the thyrotoxic periodic paralysis, which is usually going to result in hypokalemia because of the activation of the sodium potassium ATPase. And next, this excessive lipolysis and catabolic state in hyperthyroidism is important because that is the reason for weight loss in hyperthyroidism. And then hypothyroidism can result in elevated LDL, and this is also very important to understand. And again, it's having a clinical effect. And this gluconeogenesis is accelerated in hyperthyroidism, and that is again going to result in hyperglycemia, because hyperthyroidism is one of the important endocrine causes of diabetes and hyperglycemia. Yeah, so these are the physiological effects of thyroid hormones. Clear? Then, what are going to be the functions of this deiodinases? That's what we are going to see, because the next step is important in understanding the deiodinases, because this peripheral conversion of T4 to T3 is really important. So we'll move on to the deiodinase section. So there are basically 3 different types of deiodinases. You have D1 deiodinase, but remember, I'm clearly telling we are talking about the iodotyronin deiodinase here. We are not going to talk about the iodotyrosin deiodinases here. So we are talking about the iodotyronin deiodinases, which are seen in the periphery. I already told you the function of this iodotyronin deiodinases is dependent on the selenium, and because they need that selenocysteine, which is considered as a 21st amino acid. So there are 3 types of iodotyronin deiodinases or peripheral deiodinases. One is the D1 deiodinase, second is the D2 deiodinase, and third one is the D3 deiodinase. I can write here D3 deiodinase. The functions of D1 and D2 are very similar. So D1 is going to convert this T4 to T3, and they are going to degrade the reverse T3, break down the reverse T3 as well. Similarly, D2 deiodinase also, they are going to convert this T4 to T3, and they are going to break down the reverse T3 or degrade the reverse T3. But the function of this D3 deiodinase are completely different. They are actually going to convert the T4 to reverse T3. Remember, this reverse T3 is an inactive compound. It's not an active molecule. It's an inactive molecule, inactive form of thyroid hormone. At the same time, they can convert this T3 to diiodotyrosin as well. Again, this DIT is an inactive molecule, which means this D3 principally functions as an inactivating compound, inactivating enzyme. It's an image-wise depiction, so it is very clear that D1 and D3 deiodinases are present on the cell surface, and D2 deiodinases are present inside the cell. It is intracellular deiodinase. You can see this T3 that is produced by this D1 deiodinase in the periphery is going to be in the blood only. which means very, very clear this D1 dehydrogenase is quintessential for whatever plasma T3 you see in the plasma, in the blood. So the most important dehydrogenase that is contributing to the plasma circulating T3 is the D1 dehydrogenase. Similarly, this D2 dehydrogenase is the most important dehydrogenase that is going to produce intracellular T3, which is actually a functional form of thyroid hormone inside the cell. For that, D2 dehydrogenase is very important. But D2 dehydrogenase is not going to contribute to the plasma T3. That also you have to be very clear. Fine. So let us see now what will happen in hyperthyroid, hypothyroid states to these different dehydrogenases. Remember, in hypothyroid states, the function of this D1 dehydrogenases will actually decline. Why? Because T4 should not be converted to T3 in the periphery in hypothyroid states because T3 has a much lesser half-life, number one. And this D1 dehydrogenase activity that is reduced in hypothyroidism is the main reason why T3 levels in the plasma is also reduced. Actually, you will see reduced T3 in hypothyroidism, right? So why you see that reduced T3 in hypothyroidism? That is because of the reduced activity of the D1 dehydrogenase only. But remember, the D2 dehydrogenase function will increase because the T3 is the active hormone inside the cell, which means whatever T4 that is available inside the cell has to be converted to its active form, that is T3. That's the D2 dehydrogenase in hypothyroidism will be increased. Whereas this D3 dehydrogenase activity will once again be decreased in hypothyroidism because you know already the T4 and T3 available is very less and that should not be converted to inactive forms. That's the reason. Similarly, in hyperthyroid states, the activity of D1 dehydrogenase will increase. So I can write green as hyperthyroid state. In hyperthyroid state, the activity of D1 dehydrogenase will increase, and this is the main reason why plasma T3 is increasing in hyperthyroidism. Fine. And D2 dehydrogenase activity will decrease because already T4 is in excess, and inside the cell, to avoid this intracellular hyperthyroidism, the D2 dehydrogenase activity will be decreased because T3 is the active intracellular hormone. And the activity of D3 dehydrogenase will be increased again in hyperthyroidism because you know a lot of T4 and T3 available which has to be converted to inactive forms in case of hyperthyroid states. So now you have understood different actions of different dehydrogenases. Even though these dehydrogenases are located in almost all the places universally, but there are certain areas that are principally going to harbor different dehydrogenases. So for example, the D1 dehydrogenases are principally seen in the liver, kidney, muscle, and the thyroid itself. So these are the hormones, these are the areas where this D1 dehydrogenases are in high amounts. The D2 dehydrogenases, on the other hand, is concentrated in brain, especially in the glial cells, in the central nervous system, in the glial cells, and in the pituitary and in the brown fat for the purpose of thermogenesis. I didn't tell you this in the metabolic effects. So one of the important effects of thyroxine on metabolism is stimulating the brown fats to produce more heat, thermogenesis. And similarly, this D3 dehydrogenases are going to be concentrated in excess again in the brain, but for a change here, it's not the glial cells, it's the neurons, in the fetal cells and in the placenta as well. Clear? Even though I told you the substrate for D1 dehydrogenase are T4 and reverse T3, but the affinity is actually more for reverse T3, which means the major substrate for D1 dehydrogenase is reverse T3 only. The affinity for reverse T3 is more. Even though I told you the substrate for D2 dehydrogenase again T4 and reverse T3, the major substrate for D2 dehydrogenase is T4 only, because that's why they have to convert this T4 to T3 in the inside the cell. So that's why they have to have high affinity for T4 only. The major substrate for D2 dehydrogenase is T4 only. The major substrate for D3 dehydrogenase is T3. T3 and T4 both are substrate, but T3 is the major substrate for D3 dehydrogenase. So for D1 dehydrogenase, major substrate will be reverse T3. For D2 dehydrogenase, major substrate will be T4, and for D3 dehydrogenase, major substrate is T3. Clear? So you can remember this quite easily. Remember, T3 means D3 means T3, and D2 it's a multiple of 2, that is T4, and remaining only one thing you have to remember, the D1, that is reverse T3. Clear? So this is very easy to understand as well. And final point that you have to know is the fact that these deiodinases are actually susceptible to inhibition by various drugs and cytokines also. Various drugs and cytokines can actually inhibit this deiodinases. But what deiodinases? The D1 deiodinase and D2 deiodinase, but the D3 deiodinase are actually not susceptible to this effects by the drugs. You have to be very clear about that. So which means a lot of drugs and in fact cytokines can inhibit the deiodinases. But remember, only D1 deiodinase and D2 deiodinase are susceptible to this effect, but D3 deiodinase are not actually susceptible. D3 deiodinase is not susceptible to this effects by drugs and cytokines. Among the D1 and D2, the D1 is going to be maximally susceptible, that the cell membrane that is present on the cell surface, that deiodinase is the one that's going to be maximally susceptible to the effects of drugs and cytokines. So what are the drugs that can inhibit this D1 deiodinase? First drug, I can write non-selective beta blockers like propranolol. Second drug, the only thionamide, that is PTU, in high doses can inhibit the peripheral conversion of T4 to T3 by inhibiting the peripheral D1 deiodinase. Number 3, glucocorticoids like prednisolone or dexamethasone. Number 4, iodide itself. Iodine and iodide itself can inhibit the peripheral deiodinases and they can inhibit the peripheral conversion of T4 to T3. And number 5, amiodarone. Why I told amiodarone at the end is because the first 4 drugs, beta blockers, PTU, steroids, iodine, all these things are used in the thyroid storm, which I'll tell you later on in the hyperthyroidism section. All this can be used in the thyroid storm. Clear? But amiodarone we don't typically use for thyroid storm, but all these 4 drugs, why we use is one of the major reasons why we use in thyroid storm is to reduce the peripheral amounts of T3, because T3, even though the half-life is less, but it's a very, very active compound. So one of the main reasons why in hyperthyroidism you have that thyrotoxic state is because of the high amounts of T3. So reduce the peripheral conversion of T4 to T3, you need these drugs. That's why we use almost all of these drugs to in thyroid storm. But at the same time, remember that D1 is the main reason for this T3 formation in the plasma. So that's why again these drugs have an edge, because when you give these drugs, they predominantly inhibit the D1 deiodinase and they're going to reduce the peripheral T3 levels in hyperthyroid states. That's why they have an edge. And cytokines also can inhibit the peripheral conversion of T4 to T3 by inhibiting the D1 plus or minus D2 deiodinase. And the most important cytokines are interleukin 6, the most important, and the TNF alpha, obviously. So these are the 2 cytokines that are really important. In this, the interleukin 6 is the most important. And this cytokines inhibition of this D1 and D2 deiodinase is the main reason behind a clinical syndrome called sick euthyroid syndrome. This sick euthyroid syndrome is renamed currently as non-thyroidal illness, and it's also referred to as something called a low T3 syndrome. It's also called as a low T3 syndrome. What do you mean by euthyroid sick state or sick euthyroid syndrome? Remember, this sick euthyroid syndrome can literally happen in any sickness. There is no particular sickness that will result in sick euthyroid syndrome and that will not result in a sick euthyroid state, especially patients who are living in critical care. Definitely you might expect a sick euthyroid state. So what is the problem in sick euthyroid state? I told you this, any sick patient will have excessive cytokines. So let us take a sick patient is going to have excessive cytokines and inflammation. This cytokines is going to surely inhibit the D1 deiodinase and the D2 deiodinase. The D1 is the most important. Remember, this D1 is the main reason for peripheral conversion of T4 to T3, and this is the main reason for the plasma T3 that is circulating also. So once the D1 deiodinase is blocked, you are going to have a drastic reduction in the peripheral T3. So that's the reason why this syndrome is also referred to as a low T3 syndrome. Remember, the D3 deiodinase is actually not susceptible to the cytokine effect or this drug effect. So that is also one reason why D3 deiodinase will actually be working, in fact, more here, because there are 2 cell surface deiodinases. One is D1 and D3. Here the D1 is not working. So relatively the D3 effect will increase relatively. So they are going to convert this T4 to reverse T3 molecule, and the reverse T3 levels will increase in the plasma. But your T3 levels will drop in the plasma, because the D3 deadenase will not only convert T4 to reverse T3, they will also be converting remaining T3 to D8D also. So the T3 levels will drastically drop, and the reverse T3 levels will drastically rise. And this T4 level is usually normal, because T4, instead of getting converted to T3, it's getting converted to reverse T3. Usually in the initial stage, it will be normal only. That means the TSH levels also will be normal, because this T4 is the one that gives feedback to the pituitary and the hypothalamus. So I can write early 6th state and late 6th state. What will happen to the different thyroid hormones? T4, T3, TSH, and reverse T3. Reverse T3 is an inactive hormone. Remember, in early state, T4 and TSH tends to be normal, whereas the T3 levels will drop and reverse T3 levels will increase. And in late CQ thyroid state, all the hormones will decrease except for the reverse T3, which might increase. So this is what happens in severe sick state, or if the patient is having a late CQ thyroid state. Clear? So this can be easily understood from a particular image which I am going to upload now. So where you can see in the earlier stages of sick, or when the patient gets sicker and sickest, what are the changes that are happening. So when the patient is just sick but not very sick or sickest, you can see the reverse T3 level starts increasing and the T3 level starts dropping. But when the patient becomes more and more sick, in the initial stages you can see this free T4 levels and the TSH levels remains fairly stable in the early stages. But later on, as the patients become sicker and sicker, the T4 levels also starts dropping and the TSH levels also start dropping. But other two things, that is T3 and reverse TSH, will follow the standard course, that they will be either increasing or they will be T3 will be decreasing. Clear? That is the reason why there are two things that are fairly constant in CQ thyroid syndrome, that is low T3 and high reverse T3. Clear? So these two are fairly constant. That's why this syndrome is also referred to as a low T3 syndrome. So whenever in exam you get a case that is in the ICU, critical care, and they have isolated reduction in the T3, do not diagnose any hypothyroidism. Just tell it's a non-thyroid illness or a low T3 syndrome, or otherwise called as CQ thyroid syndrome. This could be an exam scenario also. They can ask like this kind of a case in the exam. Clear? Isolated reduction in the T3. But treatment wise, you have to improve the sick state of the patient and not thyroxine. Here, the levothyroxine supplementation is not going to be helpful, because you see low T3 plus or minus low T4 in the late stage of CQ thyroid. It's not the case that you have to replace these patients with levothyroxine. Levothyroxine replacement here has no purpose. You have to improve the sickness of the patient, then only this condition will automatically improve. There is no role for levothyroxine. Be very careful. There's a lot of reasons behind this, but right now there is no scope for telling all those things, but don't give levothyroxine. Okay, what sick? Any sickness, but still I have to tell some causes. For that I am telling literally any sick state, starting from starvation and malnutrition, including cancer and chronic alcoholism. Clear? Second, patients who are undergoing any trauma or surgery, you can expect this. Number 3, any patient who is having SIRS, systemic inflammatory response syndrome, like fever, sepsis, burns, pancreatitis. These are the classic examples of severe SIRS. Or any patient who is having any infection. For example, infections of the GIT causing diarrhea, infections of the CNS causing meningitis or meningoencephalitis, infections of the kidney causing pyelonephritis or renal failure itself, infections of the lungs causing pneumonia, pulmonary causes, or infections of the heart like myocarditis or even a heart failure, or literally any sick state, any organ related sick state can result in CQ thyroid syndrome. Clear? So this is the importance of understanding this peripheral deiodinases or iodothyronine deiodinases. Next, we can discuss a few points on the thyroid hormone receptor also. That's called THR, thyroid hormone receptor. Usually it's divided into two types of receptors. One is called a TR alpha and TR beta. Remember, the thyroid hormone receptor is intracellular, and in fact they are intranuclear as well, which means the localization of these receptors will be inside the nucleus only. where the thyroid hormone will translocate into the nucleus. Because it's a group 1 lipophilic, they can cross the cell membrane, they cross the nucleus, where there will be thyroid hormone receptors waiting there, and they will be binding with the thyroid hormone receptors and bring about their clinical effects. Let us see how they work. First, you have this T4 or T3. I mean, even if T4 goes into the cell, it's going to be converted to T3 by the D2-deadenase, right? So anyway, the active form is T3, no matter what inside the cell. Without this T3, usually this thyroid hormone receptor will be binding with another protein called a co-repressor, which means the thyroid hormone receptor will be inactive initially by binding with the co-repressor. Once this T3 binds with this thyroid hormone receptor inside the nucleus, that will cause displacement of this co-repressor, and T3 and thyroid hormone receptor now will form a complex. Now, this thyroid hormone receptor and T3 complex will start recruiting another protein called retinoid X receptor. This is called retinoid X receptor, RXR, and they cause dimerization. I mean, there will be dimerization of this thyroid hormone receptor with retinoid X receptor. And once the dimerization is complete, they will also recruit another protein called a coactivator. And now all these complexes like T3, thyroid hormone receptor, retinoid X receptor, and this coactivator, all these things will come and bind in the DNA regions. Those areas in the DNA that have binding regions for this complex is what we refer to as a thyroid response element, or otherwise referred to as previously we called as hormone response element. You would have studied in the chapter 1 itself. Here we are going to call it as more specifically thyroid response element. It's also a hormone response element only. Once they bind with this thyroid response element, they are going to either activate or inactivate certain set of genes, which means they can increase the transcription or decrease the transcription of certain genes depending on what are the effects that are needed to be produced by binding of the thyroxine. Clear? So this is how thyroxine is going to work inside the cell. As I told you before, the thyroid hormone receptors are divided into two. Thyroid hormone receptors are divided into two. One is called TR alpha type and second is TR beta type. All are nuclear type of receptors only. TR alpha again is divided into TR alpha 1 and TR alpha 2, and TR beta again divided into TR beta 1 and TR beta 2. These are the 4 different groups of receptor. In this, the TR alpha 1 is concentrated in most of the tissues. A lot of tissues have this TR alpha 1, but highly concentrated in the heart and the skeletal muscle. They will be concentrated in the heart and the skeletal muscle. The TR alpha 2's function is not clearly known because it is considered non-functional, because they can bind to the thyroid response element, but they cannot bind with the thyroid hormone at all. Probably it might function to reduce the activity of T3 inside the cell, maybe to fine-tune the balances between activity and no activity. But we clearly don't know the function. They are non-functional. And TR beta 1 is principally located in the brain, liver and the kidney. TR beta 2 is heavily concentrated in the hypothalamus and the pituitary, which means for feedback, these receptors are very important because the T4 is going to give feedback to the pituitary and hypothalamus of how much levels are there through this TR beta 2 only. And if you have any mutations in this TR alpha or TR beta, that will result in a clinical syndrome called thyroid hormone resistance. This thyroid hormone resistance is what we refer to as named syndrome is that's called a Refetov syndrome, REFETOFF, Refetov syndrome. Okay. So Refetov syndrome can be either due to TR alpha mutations, which are per se very, very rare, or it can be due to TR beta mutations. This Refetov syndrome itself is a very rare disease. In that itself, this TR beta mutations are common among the rarity, whereas this TR alpha mutations are even rarer, which means totally only 78 cases of TR alpha mutations have been described in the entire world till now. This TR beta mutations will have a different clinical picture. For example, laboratory wise, they will show a hyperthyroid picture. Usually they will have a secondary or a central hyperthyroidism picture, which means they will have a elevated T4 with a elevated TSH or even a normal TSH. but they'll have definitely elevated T4. Elevated T4 in the presence of normal TSH is also considered as secondary hyperthyroidism only. Why they are showing the secondary hyperthyroidism picture? Because I told you the pituitary is going to release TSH, and that is going to stimulate the thyroid gland to produce this T4 and T3. Let us assume T4 in this scenario. So this T4 is going to give feedback to the pituitary and to the hypothalamus through this TR beta 2 receptors only. So since the TR beta is mutated and it is non-functional or dysfunctional here, they cannot give a proper feedback, which means pituitary and hypothalamus thinks that there is little or no thyroxine in the system, and they're going to increase the TSH production that will activate the thyroid gland. Remember here it's a thyroid hormone receptor resistance, and it's not the TSH receptor resistance. The TSH receptor is still functioning normally only, which can be susceptible to this excess TSH producing excessive T4, which can result in a variety of clinical effects. But remember, clinical effects are predictable. Here, there will be normal TR alpha, so the patients will go for tachycardia and cardiomyopathy because of the effects on the heart. But in the brain, where you need this TR beta, because this TR beta is seen in the brain, isn't it? Predominantly, it's important for the brain. So in the brain, you can see hypothyroid effects like reduced IQ, delayed milestones, even mental retardation, and even a ADHD. So brain problems can be there. But the clinical effects, remember, even though I told you in a very simple way, it's going to be highly variable. The patient can be mimicking a hypothyroid, euthyroid, or even a hyperthyroid picture. So it's highly variable. But laboratory-wise, you're going to see a standard secondary or a central hyperthyroid picture only. If they ask you most common presentation of this TR beta mutations, it will be goiter. That is due to excessive stimulation of the thyroid by excessive TSH. Goiter is the most common clinical finding in these patients. But the actual clinical findings are highly variable, considering which organ is susceptible. And very importantly, there is one effect that is seen with this TR beta mutations. This mutated TR beta can actually interfere with the normal functioning of other thyroid hormone receptors, of other even normally functioning thyroid hormone receptors. So this inhibition or interference of the normal functioning of other thyroid hormone receptors by the mutated thyroid hormone receptor is what we refer to as a dominant negative effect, or these kind of mutations are called as dominant negative mutations. This is a very important point. One of the important examples of this dominant negative mutations is this thyroid hormone receptor mutation. And TR alpha, I don't know whether they will be asking in exams or not, but it's extremely rare. I never seen even a single case of TR alpha receptor mutations. A probable TR beta receptor mutation we have seen once when I was studying my post-graduation. Probable, but it's proven also, but still we are not very sure about that because of the lot of differences in the genomic alignment and genomic sequencing. But anyway, we are almost sure that we have found out a TR beta mutation in our during my practice. But TR alpha never. I don't know. It would be in a history because there are only 7-8 cases that have been described with TR alpha mutations. So TR alpha mutations, clinically, laboratory-wise, there will be euthyroid because TR beta related feedback is normal. Laboratory-wise, they will be euthyroid, but clinically, they will be hypothyroid. They will be having bradycardia. They can go for effusions. A lot of hypothyroid effects will be there, but it's not well characterized because only 7 to 8 cases have been described in the world. So these are the effects of mutations of thyroid hormone receptors, right? So otherwise referred to as Refetov syndrome. Now, as a final step, we have to see what are the changes in the thyroid that is happening as a result of pregnancy, pregnancy-induced thyroid changes. Remember, during pregnancy, obviously the TPG is going to increase, so your total T4 and T3 will increase. Remember, in pregnancy, we prefer actually measurement of total T4 and T3 because of various reasons instead of free T3 and T4. In all the other patients, we actually prefer free T4 and T3 only. And they will have excess HCG, isn't it? Remember, the alpha subunit is actually the same for HCG, TSH, and even FSH, LH, many compounds. The alpha subunit is almost the same. So that's why this excess HCG that is seen in the first trimester especially, the alpha subunit of this beta HCG can mimic the TSH molecule, and it can actually result in hyperthyroid-like state, which means they can actually increase the T3 and T4 levels. In fact, the free T3 and T4 levels may be increased. Clear? That is because the HCG mimics the TSH and it acts like TSH and they can stimulate the thyroid producing excessive T3 and T4, and that is what we refer to as a gestational hyperthyroidism. We'll see later on. And obviously, pregnancy is going to expand the plasma volume, which means the total pool size of T3 and T4 will expand. So increase T3 and T4 pool size. At the same time, they will have increased D3 deiodinase activity. Obviously, when you see the D3 deiodinase, in the previous slide I showed you, D3 deiodinase is important for the fetus and the placenta, which means obviously fetus, placenta both are present in the mother, which means pregnancy is a state of higher D3 deiodinase activity, which means they are going to increase the T3 and T4 degradation by converting them to D80 and reverse T3 respectively. Yes, and obviously there will be thyroid gland enlargement and the patient will have gestational thyromegaly. Clear? And because of that, the pregnant patients may have excessive thyroglobulin in the circulation. And there will be increased renal iodine clearance. At the same time, there will be increased utilization of iodine by the fetus and the placenta. So both this will increase the iodine requirements during pregnancy and lactation, where the requirement typically will be 200 microgram per day against a normal requirement of 150 microgram per day in a standard adult. Clear? So these are the changes in the thyroid that are induced by pregnancy, and many of these are questions in the exams as well. Clear? So with this, we have completed the physiology of the thyroid gland. In the next section, we'll be discussing on the ever important part, that is the workup and the investigation that you're going to use for thyroid gland thyroid related problems.